Hello, my name is Matthew George, and today I'm going to be discussing pay for performance in healthcare and whether it works with physicians, doctors, and surgeons. Now, this is a question that I sought to answer through a research paper which I wrote, which actually essentially asked the question that I just said. Does pay for performance impact the patient quality outcome when we pay a surgeon, doctor, or physician separately based on their performance? Now, before we get into this topic, I'd like to just make sure that we all have an understanding of what pay for performance is. Pay for performance, as it suggests, is a compensation model that pays workers based on results and achieving performance goals. Now, many industries have employed performance metrics, such as sports and engineering. And some claim that if workers are paid based on performance, then the quality of performance would increase to a level of cost effectiveness. That is, if we continued paying people based on their performance, it would eventually work so well that it would save us money, not cost us extra. They suggest that pay for performance would be cost effective as it only pays workers for achievements, and therefore pay for performance would be a very cost effective avenue of compensation. But pay for performance is relatively new in the compensation model history, and therefore it hasn't breached the healthcare industry too deeply. Most, if not all, doctors and surgeons are paid on a fee for service method. That is, they are paid based on each operation that they conduct. And I sought out to ask whether pay for performance in healthcare could impact a patient's health outcome after a procedure. Now, to answer this question, I teamed up with John Angnost. He's a PhD student at his first year in UCLA, and we decided to approach this question with a literary review. That is, we would read and analyze a couple different studies, we would understand the consensus and the trends in the topic, and then we would write a paper on it, essentially condensing that information. And so we wanted to narrow down the amount of studies, since obviously it is a very broad topic. We wanted to narrow it down using a couple main methods. Firstly, we limited our search to specific types of studies. Those types of studies were, well, English ones that were published in research journals, and they had to describe pay for performance as a primary variable. That is, pay for performance couldn't just be on the side, it had to be the main thing that was being discussed. We also included specific types of studies, such as other literary reviews, systematic reviews, and research studies, such as observational or experimental studies. We next used keywords, very specific keywords, such as pay for performance and quality of healthcare, pay for performance and fee for service, and pay for performance in healthcare. We used those keywords so we could kind of get at the topic that we were trying to discuss and have good keywords that we really wanted to know. And finally, we had two independent reviewers examine the studies that we selected to reduce the chance of bias while we were conducting our study. And the selected studies that we had came out to nine total studies which we had, and they range from 2006 to 2019, giving us an optimal time frame to review, meaning that we had enough time to review trends and see their impact and be able to see them as recently as just 4 years ago. This is a great spread for us to analyze. And here are the results that we got based on our literary review. The main problem with pay for performance was a lack of a compelling performance metric. This was a trend echoed by researchers and surgeons alike. Many papers suggested that there was no good performance metric, so we can't really measure it. It's difficult to quantifiably measure the performance of a physician or surgeon based on their patient outcome. So hospitals resort to a volume or amount, that is, how many operations did you conduct in a certain time frame, or how many percentage of patients with a specific issue got the operation. Now, when you use this kind of metric that relies specifically on amount or a volume, the amount increases. This applies specifically, or especially, to cases like documentation and vaccination, where when a bonus was attached for good documentation or complete vaccination of patients, the amount of vaccinations and documentation skyrocketed because of the amount. Now, very few studies actually discussed pay for performance and its impact on performance outcomes. Performance, simply put, they couldn't determine that because of a lack of a good performance metric. Now, one study did actually come out and say that pay for performance models had limited effects on quality outcomes. That is, with limits, pay for performance compensation would impact quality outcomes for patients for the better. But the biggest revelation that we had while working on this topic is discovering that pay for performance in healthcare is not cost effective. This was quite shocking to us, but it was a seeming consensus across multiple studies, and it was due to this. Pay for performance would inevitably increase documentation and vaccination and the amount of things that were done, but not to the point where it could be declared cost effective. It could get documentation to increase, but it couldn't make it increase to the point where it would actually save money. So now that we've discussed all this, what is the future of pay for performance? Simply put, how can pay for performance proceed? And it's not doomed. There are quite a few problems with it that would need to be addressed. The most prevalent among those problems would be the lack of a performance metric. Reviewers and administrators could combat this problem by conducting more research on pay for performance models. What type of performance metric needs to be present for performance and quality outcomes to increase, as well as looking at a new cost-effective way to conduct pay for performance. Now, currently, as we see in the chart, pay for performance is in a stage of evaluation. We've just evaluated pay for performance and we've noticed that there are some issues. And it takes more adjusting before we can adequately redeploy it to use in the future. Now, pay for performance is an exciting compensation model that arouses interest in me because of its potential to be a game changer in the healthcare world. And I do firmly believe that with the right tinkering and research, this compensation model could become a groundbreaking new way of conducting payment in healthcare. Thank you. It's been a pleasure speaking to you.